evaluation and management of delirium in hospitalized elderly patients. Now, as a rehab trainee, we all know it's extremely common, delirium in our elderly population. So for best management strategies, first key thing is accurate diagnosis. Secondly, using the validated tools. Third, trying to find a reversible cause. And then using our pharmacological and non-pharmacological strategies. So to talk more in detail, I'll invite Danielle Lasschuit. She is a geriatrician at Prince of Wales Hospital. She'll discuss with you guys, and then we can go from there. Danielle, please. Thank you.
Thanks, Pooja. I'm quite relieved that my talk will cover all of the things that you just mentioned. So the other thing is that it was suggested to me to ask for a show of hands who were the final year trainees in the audience. Okay, so we've got so a good number. Just to sort of try and keep you all engaged in the talk, I'm going to start with a clinical scenario, which I'd like you to think about during the talk, and then maybe the final year trainees can provide some feedback at the end as to what you would do. So I'm a geriatrician at Prince of Wales. I work on the acute ward, but I also work in outpatients in the cognitive disorders clinic. And I also do some outreach work up in Port Macquarie and Kempsey, providing Aboriginal older outreach program up there. So to begin with a clinical scenario, we have an 84-year-old male from home who's been admitted with reduced mobility following a fall with a left pubic rami fracture. His background includes Parkinson's disease, atrial fibrillation, benign prostatic hypertrophy, and he's hearing impaired. These are his medications, so he's on Matapar, amitriptyline, apixaban, metoprolol, and since he's been in hospital with the pubic rami fracture, he's been commenced on some low-dose Targem as well as PRN endone for pain. Because he's been slow to get up and moving, he's been referred for rehabilitation to improve his function with the aim of returning home. On day 3 of his admission, he has been noted to be acutely agitated and he refused his evening medications. So the nursing staff page you. They've managed to get a temperature that's moderately elevated, 37.8, but he's refused any other observations. They can't recall that he's passed urine since midday. He's repeatedly attempting to get up, says, "I'm going home." And the nursing staff said, "Look, we just really need something to sedate him, please." So what are you going to do for this gentleman? So that's to think about, and we'll come back to that at the end. So the learning objectives in the next hour or so are to know the common causes of delirium, to understand the risk factors, to know how to use screening tools, to identify delirium, and we'll talk about 2 of the common screening tools that we use, to be able to come up with investigations to identify a cause, and then we'll talk about management. So I guess just to highlight that prevention should be the goal. We know that delirium is preventable. However, when it does occur, what are the non-pharmacological and pharmacological options? And then at the end, we'll briefly touch on outcomes and prognosis. So to start with a definition, the DSM-5 is only slightly different to the previous DSM-4 definition of delirium, which describes the following 5 key features. So there's a disturbance in attention. So often you'll see patients either having difficulty focusing or sustaining attention, or having trouble shifting onto another topic, and a change in orientation. Typically, this develops over a short period of time, and by short we mean sort of usually hours to days. It represents a change from their known baseline, and there tends to be obvious fluctuation during the course of a day. So, for example, just on a ward round yesterday, my registrar had attended a patient an hour before me, didn't think the patient was delirious, and when I went there, the patient was clearly drowsy and confused. So that can happen over the course of 30 or 60 minutes. There's usually an additional disturbance in cognition. So in addition to the poor attention concentration, often there's some memory impairment. They may be quite vague as a historian. There could be language changes or changes in perception. Typically, there's no better explanation for why these changes have occurred. So, in particular, that it doesn't represent a sort of gradual progression of an underlying dementia or other neurocognitive disorder. And often we only really know that by getting a collateral history. And there's usually, not always, evidence that the disturbance is a direct physiological consequence of some underlying condition, substance intoxication or withdrawal. And in most cases, actually, there's multiple etiologies that underlie it. In addition to those 5 sort of key features, these are the additional features that commonly accompany delirium. So usually there's some sort of psychomotor behavioural disturbance, and that can either be hypoactivity or hyperactivity with increased sympathetic drive. And very commonly there's an associated sleep disturbance. So there's often sort of disruption to the usual circadian pattern, and often people are awake and agitated during the night and then drowsy during the daytime. And there can be variable emotional responses that patients sort of manifest as a result of the other features, and often people are quite afraid. They might appear hypervigilant, and sometimes they appear teary or depressed. So that's the definition, but what's the reality of how it presents? And often it's, they're just more confused today, doctor, or, this patient's not themselves. The nursing staff might report, look, he had a really bad night, he was confused, up and wandering, but he seems okay now. Sometimes it can just be simply, the vague historian. So this report that a patient can't really give a history, they've got poor attention. It might be obvious because they could be agitated, responding to external stimuli, plucking at clothes, that sort of thing. The more challenging patients to recognise are often the hypoactive, delirious patients, because they're not really causing anyone too much trouble. They're quiet, they might be drowsy, and sometimes sort of the indication of that is the food tray is just untouched, or they just have a reduced ability to care for themselves. Often there's in particular in elderly patients, there's often an accompanying loss of mobility that goes with delirium. And in some cases, it's quite obvious because the nursing staff say, you need to do something, they're about to leave the ward. So I guess why is delirium important? Well, it's very common, and in a vast number of cases, it's often not diagnosed. We know that it increases length of stay. We know that it's associated with hospital complications. We know that having delirium increases your chance of having a poor outcome, such as mortality or admission to residential care. Delirium often takes a long time to get better, often much longer than the underlying precipitant, and it doesn't always get better. We know that it can be prevented, it can be treated, and if it does occur and we put good care and management in place, often we can shorten the duration of delirium. Good communication is reassuring not only for the patient but for the carer and family, and helps to set up realistic expectations as well, and good practice saves money. So what's the epidemiology in hospitalised older patients? Well, delirium accounts for about 50% of hospital days. So you'll know the difference. So prevalence is a condition that is existing when the patient comes in, incidence and new cases diagnosed. So on general medical and surgical wards, the prevalence is up to about 1/3 of patients. However, the incidence is up to 50% in older patients. And in intensive care, those numbers are particularly high. So up to 80% of older patients in ICU will have delirium, and that's certainly our experience if we are ever involved in looking after elderly people in ICU. The non-detection rates are estimated at 1 to 2/3 of patients. So just to highlight that we need to sort of have effective screening and have a high level of suspicion. And I think often it can be tricky because delirium can be attributed to other causes such as pre-existing dementia or to a mood disorder such as depression. So this is sort of a common table that you'll find in any textbook, and you've probably all seen, but just to sort of, I guess, remind everyone, so distinguishing delirium from dementia, the onset and course are different. So whereas dementia is generally a gradual onset and progression, delirium has acute onset and usually fluctuates. The duration in delirium hopefully is days to weeks if we can find a reversible cause, often longer. However, dementia, as we know, progresses gradually over months to years and usually is not reversible. Consciousness and attention, so in delirium they're altered. In dementia, typically patients are clear in their consciousness and often have normal attention unless they've got very severe dementia. Psychomotor changes are common in delirium, much more so than in dementia. Hallucinations are common in delirium, and apart from Lewy body dementia, hallucinations tend to appear only in more advanced stages of Alzheimer's or vascular disease. And delirium is usually reversible, at least to some extent, whereas dementia is not. So I guess in terms of identifying patients or sort of having a feel for who is at high risk of delirium, these are the main risk factors. So older age certainly is the number one sort of risk factor, as well as pre-existing brain disease. So patients who are known to have underlying cognitive impairment, previous strokes or neurodegenerative conditions such as Parkinson's disease. Patients who are known to have substance and alcohol abuse, patients with pre-existing functional impairment, hearing or visual impairment. Previous delirium is a risk factor for further episodes of delirium and underlying depression. And then the precipitating factors, which I guess are what we consider to be the causes of the delirium, are multiple, but these would be the most common ones. So certainly medications, and beware of polypharmacy as well. I'll go into a full list of medications on the next slide. Acute illness, so infections typically. Metabolic derangements, dehydration, just to name a few examples, recent surgery, drug or alcohol withdrawal. It seems really simple, but we always look for constipation and urinary retention because you'll be surprised how often it's something really simple that's driving the delirium. And if you don't do a bladder scan, often you'll miss the fact the patient's in retention. Same with keeping a really accurate bowel chart. It's simple, but it's good care. And then environmental changes, so particularly things like multiple bed changes, being across different wards, being in the intensive care unit, having some restraints, being immobilised, and having an indwelling catheter. So in terms of medications, obviously there are many. I've put some in bold just, I guess, to highlight the ones that we see commonly. So obviously anything that's centrally acting is well known to be able to cause delirium. Commonly the antipsychotic agents, benzodiazepines, the dopamine agonists used for Parkinson's disease. In terms of analgesia, opioid analgesics are, common culprits, and the antidepressants as a class as well. I guess they're the ones that everyone sort of, thinks about. Some lesser known ones to be aware of are patients with detrusor, instability and overactive bladder are often on these antimuscarinic agents, oxybutynin or Vesicare, solifenacin, and they're quite potent anticholinergics. So particularly in people with underlying cognitive impairment can cause confusion. The antiemetics as a group as well as histamine antagonists, so things like ranitidine, which you might not think about, and also the beta blockers as a class, particularly the lipophilic beta blockers that cross the blood-brain barrier. So I guess propranolol, and propranolol is strongly lipophilic. Metoprolol is sort of intermediate. The ones that are least likely to cross the blood-brain barrier are atenolol and sotalol. Beta blockers also have an effect on melatonin secretion, so can be associated with sleep disturbance in patients too. So there used to be a question about pathophysiology of delirium in the physician exam, and it's been removed because we realised that we don't really know. But it seems likely that reversible impairment of cerebral oxidative metabolism is a final common pathway into which a number of other pathways feed. And the following are sort of a list of proposed mechanisms. So we know that there are neurotransmitter abnormalities in delirium, and I'll go into which ones. We know that direct brain insults obviously can cause delirium because there are structural changes, so things like a stroke. There's been a lot of work done around a proposed neuroinflammatory pathway for delirium, and I guess this helps explain why, an older person who may have some underlying cognitive impairment who has a relatively minor urinary tract infection without any systemic symptoms can suddenly become delirious. And this is this sort of neuroinflammatory proposal. So there are peripheral release of cytokines. And in delirium, as well as in other states, so we know in ageing, diabetes and dementia, there's an altered permeability of the blood-brain barrier to these inflammatory cytokines, and they then can have central effects. The other thing that seems likely is that there's an aberrant stress response in a lot of older people that perpetuates delirium. So older people have an impaired feedback via the limbic hypothalamic pituitary adrenal or HPA axis, and this results in, so normally when there's a stress response there's a sudden surge in cortisol which gradually dissipates. In an older person that cortisol can remain sustained at high levels for much longer after a relatively minor insult. And there seem to be some changes in melatonin secretion as well. So you'll all be familiar with melatonin being a hormone that's involved in circadian rhythm and sleep and normal sleep patterns. So in terms of the neurotransmitters that we know to be involved in delirium, we know that acetylcholine deficiency plays a role, and there's a lot of evidence around acetylcholine and cognition. We know that even in healthy volunteers, if you give them an anticholinergic drug, they can get delirious. We know that in Alzheimer's dementia, where one of the primary pathologies is a loss of cholinergic neurons, these people are predisposed to delirium. And we see with energy deprivation states such as hypoxia and hypoglycemia that these can lead to a reduction in acetylcholine synthesis. Dopamine excess also seems to have a significant role. Dopamine itself has an inhibitory effect on the release of acetylcholine. And we know that the dopamine antagonists, so the antipsychotic agents, can be helpful in treating hyperactive symptoms of delirium. The GABA receptor, so one of the GABA's the primary sort of inhibitory neurotransmitter in the CNS, agonists or modulators that work at that receptor can trigger delirium. So these include alcohol, benzodiazepines and propofol. And back to the stress response. So we know that sustained high cortisol levels can cause cognitive impairment and other neuropsychiatric deficits. We know this from studies where healthy volunteers are given high-dose glucocorticoids and develop impaired attentional memory. And also Cushing's disease, where there's sustained excess cortisol. These patients over a longer term develop brain atrophy, they can develop multiple cognitive deficits, they can even have increased risk of neuroaffective disorders and psychosis. So I guess back to a more clinically relevant slide. So what's your approach going to be? So if delirium's suspected, I guess these are the 4 things that we need to look for, and I'll go through some of the validated screening tools after this, and you'll see that both of the screening tools effectively are using this diagnostic approach. So the first thing is assess arousal. The second thing is we need to make some attempt to test cognition, and the ones that I do on my ward round are I do the abbreviated mental test 4, so the AMT4, that involves asking the patient where are we, and so being able to correctly identify and name the hospital, what year is it now, when's your birthday, so they have to tell you their date of birth, and they have to tell you their age, and that's the AMT4, and that's incorporated in some of the screening tools. And the second test is a test of concentration, so months of the year backwards. And you can give them 1 or 2 prompts, but most patients should be able to get about 7 at least of the months of the year backward. If they really can't do that, you can try days of the week backward, but start with months of the year. We need to establish that there's an acute onset and that there's a fluctuating course, because otherwise this could just be dementia. And usually, I mean, unless you've been looking after the patient and this is a sudden change, so you know for sure that it's acute onset, often you need an informant history to establish that, so speaking to the carer or the nursing staff. And then don't forget to assess for the additional features that we know can accompany delirium. So looking for evidence of hypo or hyperactivity. And patients are often reluctant to, even if they're aware they're having psychotic features, they're often reluctant to admit to that, because sometimes, you know, they're worried they're going crazy or you think they're crazy. So the best way to know about that is to actually ask directly. So often what I'll say is, look, when people get sick and they need to be in hospital like you have been, it's actually quite common for people to experience strange things, like seeing things that might not really be there. Has that happened to you? So you sort of normalise it, and often people will say, well, actually, yes. Sort of paranoia and suspicion is a little bit trickier to ask about, but often you can just say, have you been concerned about anything that's been going on lately? And they might come up with some quite paranoid thoughts that they've been experiencing. And look for sleep disturbance, and often the best way to do that is just to read the nursing notes overnight. So now I'll take you through 2 of the validated screening tools that I was mentioning. So the first one, this is the one that we use at Prince of Wales, is the CAM, or Confusion Assessment Method. It's pretty simple. To demonstrate that delirium may be present, you just have to demonstrate that the patient has both an acute onset or a fluctuating course of cognitive changes, and that there's inattention present. And in addition to those 2, they either need to have disorganised thinking or an altered level of consciousness. And if you've got 1 and 2 plus either 3 or 4, then the sensitivity and specificity are actually quite high for detecting delirium. Internationally, the 4AT is actually quite widely used, and I think is gaining a lot of favour as well. And I know that I think St George Hospital uses the 4AT. I'm not sure about, you may know about your own hospitals. But the advantages of the 4AT, it's a clinical instrument that has a high sensitivity and specificity for detecting delirium. It's quick to administer, which I think is essential for any screening tool. There's no special training required, and it can be used in normal clinical practice, such as on the wards. An advantage is that patients can be severely drowsy or agitated and still be assessed using this screening tool. So otherwise untestable patients can be assessed. And it includes the brief cognitive tests that I mentioned that a lot of us use in our routine clinical practice anyway, the AMT4 and the months backwards. So I'm not sure how well that projects, but you can look up the 4AT, the PDF's available online. Essentially, again, there are 4 components. So you assess alertness, and you walk up to the patient, you observe them without interacting, just are they asleep, are they awake, are they engaged? If they're asleep, a simple sort of rub on the shoulder and say, hello, it's the doctor here, see if they wake up to normal voice or light touch. And you might ask them their name and to say where they live, and that will be enough for you to say whether they are normal level of alertness, whether they're mildly sleepy for less than 10 seconds but then wake up normally, or whether they're clearly more drowsy. The AMT4 we've already been through, so you ask those 4 questions and score them accordingly. Assess attention using months of the year backwards, and then establish whether the changes are acute and whether there's a fluctuating course. So for each of those, they get a score between 0 and 4. Scores of 4 or above are suggestive of delirium plus or minus cognitive impairment. Scores of 1 to 3 suggest cognitive impairment without delirium. So that's quite a useful tool as well, and I know is being quite widely used. So we mentioned before that there are different delirium phenotypes. So I think the hyperactive, most people find the easiest to recognise because you sort of have to do something about it. So patients are often agitated, restless. There might be evidence of psychosis, emotional lability. And it's common in acute alcohol withdrawal, where there's cerebral sort of hyper, sort of excitatory state. The so that's about 30%. The hypoactive form is seen in about 1/4 of patients. I think it's the most under-recognised because, as I said, those patients are sort of easy to look after. They're quiet. They don't cause too much trouble. But the issue with them is that they're not eating, they're not drinking, they're not getting their medications, they're not mobilising, they're just lying in bed. And so they have worse outcomes associated. And the most common is actually to have a mix of the 2 phenotypes, and that's seen in about 45%. And they're those patients where, they at one point they're agitated, and then the next time they're almost unrousable to the point where the nurses aren't sure whether to call a code blue because they can't be woken up. So once we've sort of screened for delirium and we've decided that the patient has delirium, I guess the important thing is to know what medical assessment you need to do. And I guess that always starts with the history. So the important things in particular to know about on history are you need to get a really accurate medication reconciliation, and you need to know particularly if any new drugs have been started, or if patients have if any drugs have been withheld. So often patients won't report how much benzo they actually take, and they come into hospital. They can go through acute benzodiazepine withdrawal because we weren't aware that they were actually self-medicating at home. And be aware of potential drug interactions as well. It's really important to ask about any pain or discomfort, because that can help you localise where some acute pathology might be. But also addressing pain can help prevent delirium. And as I've already mentioned, urinary retention and constipation are common, so always think about that. There's nothing specifically on examination, but I guess, you know, just looking for underlying causes, so a set of vital signs, looking for any obvious foci for infection, and, you know, always think about, could this be a central cause? So looking for focal neurology that might suggest an underlying stroke or some other sort of acute neurological cause. I guess the other thing on there, sorry to mention, is although it's rare, you need to consider non-convulsive status epilepticus in patients that remain drowsy and you can't find any other cause. And every so often we'll do an EEG on somebody to exclude non-convulsive status, and that will turn out to be the cause of you know, a persisting drowsiness in patients. So first-line investigations, you know, a full set of bloods, looking for anemia, looking for electrolyte abnormalities such as, you know, hypo or hypernatremia, hypercalcemia, looking at glucose levels. LFTs may indicate, you know, an underlying hepatic issue. Always screen for thyroid function and B12. If not done recently, sometimes patients are in and out of hospital, you know, every 3 months, and if it's been done recently, there's probably no need to repeat it. Patients who are on drugs that have therapeutic windows, we should be checking levels, particularly if they're on things like lithium or anticonvulsants. And generally we'll do a septic screen, so we'll check a urine, we'll do a chest x-ray, you know, if it's indicated, do blood cultures. Post-void bladder scans, often helpful, and I've put this under first line, but it's sort of, you know, if indicated, to think about doing an ECG and a troponin, because myocardial infarct can be a precipitant for delirium. So patients are complaining of chest pain, they're short of breath, they've got risk factors, that's something to consider. In terms of second line investigation, so if you haven't been able to establish a cause, you'll need to cast the net more widely, because it's really about trying to find something that's reversible. So thinking about looking for, you know, blood gas disturbances, so hypoxia or hypercapnia. An abdo X-ray can be helpful, particularly if you feel that it could be significant fecal impaction. There's an interesting study from 2008 that looks at the utility of doing a CT brain in patients with delirium. Essentially, you know, it's only really indicated if there's focal neurology or we suspect head trauma. Interestingly, in this study of about 300 patients, if there were no focal neurological abnormalities and there was a better explanation, so if patients had fever or dehydration, 96% of CT brains were normal. And if they had no focal neurological abnormalities and baseline dementia, 98% of scans were normal. So I'm not saying don't order a CT, but sort of think about what yield you're expecting, I guess, if you're going to do one. As I mentioned, an EEG can sometimes be useful to exclude occult seizures or non-convulsive status. They're usually unhelpful in other causes of delirium because they just show diffuse slowing. However, sometimes if you're trying to establish whether this is an organic cause or an underlying psychiatric or functional disorder, an EEG can be helpful. We rarely progress to an LP because usually by this stage we've found several reversible other causes. But, you know, if you really are concerned that there could be an infective or inflammatory sort of CNS process going on, or paraneoplastic process, an LP can be considered, as can HIV and syphilis serology in, you know, certain patient groups. So moving on to management, as I mentioned, I think prevention is the thing that, you know, we need to be aware of and focus our efforts on. Once delirium's occurred, how are we going to reduce the duration? So we address underlying causes. We'll talk about environmental and non-pharmacological strategies. There's a limited role for pharmacological management in delirium. I think it's important to educate family and carers right from the start. So we talk about what's precipitated it. We explain that the fact the patient looks better today, you know, may not mean that they're actually improving. They could be fluctuating. And we talk about prognosis. You know, I think once you've done the workup, if you're still struggling with ongoing delirium symptoms, consider referring to the delirium CNC in the hospital, because they can often provide a lot of good advice around behavioural and environmental strategies. Consider referring to the geriatrics team if you'd like further input. I think consider capacity issues around consent if patients are clearly, you know, confused, and particularly if you're thinking about doing anything that would require, you know, patient consent. And in the longer term, these patients probably should be followed up. We know that delirium is associated with accelerated cognitive decline down the track, and we know that it's a risk factor for developing dementia. So we're very happy to have referrals in the memory clinics to follow up patients who've had delirium in hospital. So maybe just a show of hands for this question, which we're talking about prevention. Which of the following interventions is least likely to have prevented delirium in our patient? Olanzapine, melatonin, opioid analgesia, providing hearing aids, or frequently reorientating the patient. So show of hands for A. Okay. Show of hands for B, C, D, and E. Okay, so I think it's either A or C. So, I mean, opioid analgesia, whilst it can precipitate delirium, I think management of pain is important in preventing delirium. We know that in patients with Parkinson's disease, we need to be really careful with using antipsychotics, and there's also not great evidence for antipsychotics in delirium. I'll go through that in a minute. So I think probably olanzapine is least likely to be helpful. Yeah. Yeah, that's a good question. We would use melatonin as a first-line agent. If people are dependent on benzos and have been on them for a long time, I wouldn't suggest abruptly stopping, but I would suggest a titration. So I would suggest reducing the dose. If they're on very low dose and they only take it occasionally, you can just stop it. But definitely we use quite a lot of melatonin with varying effect. I think that's first line. Second line, depending on if it's a long-term sleeping problem, we'll often use something like, depending on their other symptomatology, sometimes something like mirtazapine. If they've got underlying cognitive impairment and we're trying to treat a little bit of mood as well as sleep, sometimes some of the antidepressants can be a little bit safer than benzodiazepines as well. But I couldn't really, I guess it's sort of tailored to the individual patient, but I think melatonin is a reasonable starting point. Is there any dose of risk of falls with melatonin versus? Yeah, I mean, there's certainly a risk of falls with all of the antidepressants, and with benzodiazepines. Melatonin, no. So it's certainly got the best side effect profile. And we know that older people, as well as people with delirium, often have reduced melatonin secretion. So it's a good physiological place to start. And then I think, you know, all the other medications have side effects, and you've got to consider what you're trying to achieve. Yeah. Yeah. So I guess this slide is talking about prevention, and there are studies that look at preventing delirium with antipsychotics, but it's not part of our routine clinical practice. So we wouldn't routinely suggest putting people on antipsychotics to prevent delirium. Yes, when delirium occurs, depending on what the situation is, if people are extremely agitated and you need to achieve some degree of sedation to be able to administer care, you know, do urgent investigations, there is a role for antipsychotics or sedation. In Parkinson's patients, we tend to prefer quetiapine actually as having the least extrapyramidal side effects. I'll go into that in the next slides as well. So just the first few slides are about prevention, and then we talk about medication once delirium is established. So there was a meta-analysis in 2015 that concluded that multi-component intervention strategies are effective in preventing delirium and functional decline, and these are the sorts of things that were looked at as a multi-component approach, so regular reorientation and reassurance. So we've actually gone through the aged care wards. We've put up big clocks that are highly visible with dates in each of the rooms. Try and have patients near windows so that they get normal daylight and normal nighttime. Try and minimise room changes. Cognitive stimulation helps, so involving family and carers, having them come in during the day, bringing in things that might be familiar to the patient, their own clothing or photos of family members. Certainly correcting sensory impairment, so insisting that people have their hearing aids brought into hospital and their glasses are available. Ensuring adequate hydration and nutrition, and you know, for us in acute that often involves close communication with surgical teams to make sure patients aren't being fasted for excessive periods of time, early mobilisation, as well as limiting restraints. So try to avoid catheters. You know, we do use one-to-one specials in, you know, if we really need to, rather than trying to restrain patients physically. Promoting sleep is really important, and sometimes simple things like, you know, in stable patients, the nurses don't have to wake them up at 2 in the morning to do a set of observations or administer medication. Trying to keep people awake during the day. Reducing medications that have anticholinergic side effects, good pain management, and good bladder and bowel management. So, I mean, they're all really simple strategies, but if done well, can certainly help prevent delirium. Then going into some of the medications that we were talking about, interestingly, although we know that there's a deficiency of acetylcholine in delirium, unfortunately the cholinesterase inhibitors that we use in Alzheimer's dementia have had negative trials for helping to prevent delirium. The antipsychotics have been used in mostly actually in surgical, in sort of elective surgical patients with inconsistent benefits. So there does seem to be some evidence from the studies that the incidence of delirium can be reduced with preoperative antipsychotics. However, the patients who go on to develop delirium have an increased severity and duration of delirium. So it's a pretty heavy price tag for a reduced incidence in some patients, and we certainly don't do that routinely. there is a lot of interest around melatonin, and there's at least 3 randomised controlled trials now that show a significant reduction in incidence of delirium in different patient cohorts. So you can see 12 versus 31%, 3 versus 32%, and 9 versus 33%. So significant reductions with use of melatonin. I only mentioned this one briefly, dexmedetomidine, which is often used in ICU settings. It's an alpha-2 adrenoreceptor agonist that provides sedation and some analgesia, but of benefit minimal respiratory depression, and low-dose dexmedetomidine has been shown to reduce post-op delirium in non-cardiac surgery ICU patients. And some of that may be because it causes less hypoxemia, less pain, and improved sleep quality in the treatment group. So on to the question about antipsychotics. I guess sort of the umbrella statement is that the current evidence does not support the use of antipsychotics for the prevention or treatment of delirium. However, obviously there are specific cases where we don't have a lot of alternative. We need to be aware that antipsychotics and sedatives can prolong duration and severity of delirium. However, there are patients where it may be required because of severe agitation, and this might be where we actually need to be able to investigate or treat underlying conditions where there's a risk of harm to self or others. Patients who have really severe distressing psychotic symptoms that are hampering, our efforts to actually administer treatment. So in these patients, I think the first thing to say is all of these patients should be on a behaviour chart so that we can actually see when the symptoms are occurring, and 2, if we give an antipsychotic, is there actually a benefit? Because there's no point giving the antipsychotic unless there's evidence of response. So anyone who you're starting antipsychotics, also ask for a behaviour chart, and then start low and go slow. So, haloperidol and risperidone are in general the first line agents that are used in most hospitals. However, in Parkinson's disease, we need to be really careful, and I would suggest quetiapine in low doses starting at 12.5 milligrams up to 25 milligrams. So we're talking really low doses here. And obviously in hypoactive delirium, there's no role for antipsychotics or benzos because really we're using them to prevent agitation. I think if you're going to prescribe antipsychotics, you need to be aware of the side effects, and you do need to also inform family if we're planning to use antipsychotics for any duration of time. So, overnight you can treat under duty of care, but if we're going to be using antipsychotics regularly, we need to tell family that we're using these medications, that there is a very small increased risk of stroke and mortality in older people. We need to be aware that they can cause extrapyramidal side effects, which is less common with the atypical antipsychotics than the typical. Be careful with QT prolongation, particularly if people are already on, say, an SSRI or other medications that can cause long QT. And if you're concerned, you can do a baseline ECG before you start the antipsychotics. And we know that antipsychotics are associated with an increased risk of falls as well as postural hypotension. I won't go through this. It basically just summarises the intervention trials that we've already discussed for post-operative delirium. Just to quickly mention, alcohol withdrawal is sort of a bit of an exception to the rule of what I've said, so I just thought I'd mention it because alcohol is a CNS depressant via the GABA and glutamate receptors. Abrupt cessation of alcohol causes CNS overactivity. And so it, against sort of the previous advice not to use benzodiazepines, obviously in alcohol withdrawal, that's a situation where you would use benzos to control the psychomotor agitation and to prevent progression to more severe withdrawal or even delirium tremens. And just to remember that these patients may need IV fluids, they may need IV thiamine and glucose. And I won't go through that, but that's sort of the withdrawal symptoms to look out for. Probably by the time people get to rehab, in most cases you would think that they would have been through their withdrawal. Okay, so just back to our clinical scenario. So we've got our 84-year-old male with the pubic rami fracture. We know he has Parkinson's, benign prostatic hypertrophy. He's on those medications and he's suddenly become agitated. So some of those people who put up their hand, does anyone want to suggest maybe maybe the first question is, what are the risk factors that this guy has for delirium? Or anyone, you know, feel free to call out some answers. Yep, so Parkinson's, pain, did you say? What else? Age? So you're sort of going into some of the precipitants as well. So the risk factors certainly are age, the fact that he's got Parkinson's disease, so a sort of, you know, abnormal brain to start with. Yeah, okay, he hasn't had an operation, but he does have pain. And the other one I would probably say are the hearing impairment. So he's got sensory impairment. And then, yes, so some of you already identified what some of the precipitants are. So we've mentioned, what did we say, medications? So which medications in particular? Yep, so I guess the new medications are always the ones we look at first. So potentially his opioids. Anything else? The Matapar, yeah, so he's on, so he's, of his existing medications, actually quite a few of them could contribute, couldn't they? So he's on dopamine, he's got amitriptyline. I'm not quite sure why he'd be on that, but, you know, often older people are on that for sleep or for some sort of previous depressive symptoms, but certainly that's anticholinergic. And also, you know, to a much lesser extent, perhaps the metoprolol could be contributing too, but the new thing is the opioids. Yeah, thank you. So, I mean, something's happened because he's now got a low-grade fever and the concern is that he's not passing urine. So how would you do? What would be your approach to that? Bladder scan. Okay, so he's got 850 mils in his bladder. Yeah. Yeah. Yeah, so they're all good thoughts. I guess the difficulty is, I don't know that we're going to be able to get this guy to agree to a catheter, and also putting a catheter in, he's at higher risk of causing harm. So, I mean, potentially we would attempt to get him up and see whether he can pass urine. You know, as you mentioned, constipation, so reviewing his bowel chart, you know, if it's indicated, you could trial an enema. And just see if we do need to address the retention very urgently. So unless he's able to sort of get up and pass some urine, we might have to put in a catheter in the short term to allow the other investigations that you've mentioned. Yes, thank you. Yeah, so correct everything that we can that's reversible. So get his hearing aids. You know, sometimes just approach him, introduce yourself, you know, get rid of all the other people in the room, sit down, try and calm him down. Can I get you a tea, some biscuits? Get him on side. You'll be surprised how easily that can work. Ask the family what he likes. If he loves cheese and crackers, get him cheese and crackers and, you know, try and start to calm things down. So really look at your environmental strategies. So we discussed the risk factors and the potential precipitants. So I think, you know, the nurses want to sedate him, and, you know, that may be required if we need to. He's not going to calm down while he's got 800 mils in his bladder. So, you know, if we need to, we might have to sedate him, but try the environmental things first. We need a collateral history so that we can find out, you know, with his Parkinson's, does he have Parkinson's disease? With dementia, does he have Lewy body dementia? And who is this person? Like, what sort of work did he used to do? What are the likely triggers for behaviours, and what can we do that's going to help? And the family might come up with some really useful strategies. We need to address all the reversible causes. So we talked about retention, constipation. You know, think about what his risk factors for retention are. So obviously autonomic dysfunction associated with his Parkinson's disease, opioid analgesia causing constipation, his anticholinergics. We need to screen to make sure he hasn't developed a urinary tract infection. Reviewing his meds. You know, he probably should be on regular Panadol Osteo if we're going to have him on, you know, stronger painkillers. And we mentioned the apixaban and concern for potential pelvic pathology, which I think is a good suggestion. And also, you know, do we need to scan his brain, because could he have had a subdural at the time of the fall? And that would be done when he's more cooperative. So, you know, we are going to aim not to use pharmacology, but we might have to if we're going to. We need a behaviour chart. We're certainly going to write in big writing to avoid haloperidol, so that he doesn't get given any overnight by more junior medical staff. If we're going to use an antipsychotic, I'd use quetiapine at low doses. If we need to sedate him to, say, get a catheter in, you might even consider needing to use a low dose of a benzo, just short-acting. But again, you just got to judge it. And I would probably start him on melatonin as well to help with his sleep. Okay, so we've got 0 minutes left, but I've only got 3 slides. So just very quickly, we're just talking now about outcomes of delirium. So 75-year-old lady admitted to hospital with a community-acquired pneumonia. She's from a retirement village. We know she has moderate Alzheimer's disease. 11 o'clock after admission in the morning, she's asleep. She's mildly confused, not orientated to place. Her breakfast and her food tray has been untouched. The nurses say she's very agitated overnight and was pacing the ward. Show of hands or call out. Which of the following is incorrect? Her mortality risk is 40%. Her condition is unlikely to have resolved at discharge. A CT brain is unlikely to reveal the cause of the condition. Pressure ulcers and malnutrition are likely outcomes, or her lack of agitation at present suggests recovery. So 4 are correct, 1's incorrect. E is incorrect. Yeah, very good. So we've already discussed that. So A and B I'm about to show you the stats for. We know a CT brain probably will be normal. And we know that pressure ulcers, malnutrition, aspiration pneumonia are all she's all at high risk of. So the outcomes, delirium increases length of stay, it increases hospital-acquired complications such as falls, pressure injuries, aspiration pneumonia, DVT and malnutrition. There's a 3 to 7-fold increased risk of a new admission to residential aged care. And the mortality is sort of surprisingly high. So during admission, 20 to 75% mortality. And even out to 6 to 12 months, mortality rates 35 to 40%. And there are increased rates of cognitive decline following an episode of delirium. In terms of duration, you know, this mean duration of 7 days, often we see it's actually longer than that, and often it's much longer than the original precipitant that caused the delirium. So rates of resolution at discharge, only about 50% of people have completely normalised to their cognitive baseline. You know, the other 50% might be significantly better, but they're not back to baseline. And even out to 6 months, approximately a fifth of patients still won't have had their delirium resolved. Okay, any questions? I mean, I guess ideally that would be great. I suppose our resources are, we don't get referred everyone who's had a delirium anyway. I think if you have somebody, particularly if the delirium was from a relatively minor precipitant, or if it's their second episode, or if you suspect from the history that they were already cognitively impaired prior to the delirium, we'd be very happy to see these people as follow-up. Yeah. Yeah, sure.
Please join me in thanking Danielle for a wonderful presentation. Thank you so much for making it exciting.
My name is Angela, and I'm an endocrinologist. I work mostly in Sydney East, and I'm also doing a PhD at the Garvan. My interest is in particular in osteoporosis and bones. So hopefully this will give you just a bit of a brief overview over some of the concepts about osteoporosis. I think most of you will know a lot of this, so bear with me if it's a bit simple. But hopefully there's a bit of time for questions at the end, and if you want to ask any questions throughout, just pop your hand up. So today, I think you've got handouts already, but this is what I'll be going through, just the relevance of bone physiology and the impact of osteoporosis and fractures in particular, and then some of the diagnostic and management principles that are relevant to our patients. So the bone structure and function is pretty straightforward. Our bones are there for mobility and protection, and that's why we need strength and density. Our bones are made of both cortical or compact bone as well as cancellous or spongy bone. And it's particularly the spongy bone that is important for the reservoir for ions, so calcium in particular, but also hematopoiesis. But this is important because the type of bones the type of bone within each of the bones are different. So particularly in the vertebra, you get predominantly trabecular or cancellous bone, whereas in the hips and in the wrist, you get predominantly cortical bone. And so that sort of makes sense because they're the sort of weight-bearing sites. And that's important because of the way that as bone remodelling occurs and in pathological conditions, different parts of the body are particularly preferentially affected. So postmenopausal women, for example, particularly get trabecular bone affected, and that's why they get vertebral fractures in particular. Some conditions such as hypoparathyroidism, that particularly affects cortical bone. It's probably not so relevant for you, except just to think about the fact that there's going to be people who, when you think about their bone density, that gives you a reason sometimes why some people have particularly bad spinal density compared to hip density or vice versa. And you still need to think of them, even if one of them is really disparate from the other, that it is still relevant that they've got weaker bones. Bone remodelling, as we grow and hit the growth spurts, particularly in adolescence, we get taller, and then once our growth plates fuse, we start to build bone density. However, bone remodelling occurs lifelong, and it's actually quite an active process that requires a degree of metabolic function. And so conditions such as Paget's disease, or in conditions where the bony metastases, that takes a lot of metabolic supply for the patient. Bone remodelling is important because it actually repairs micro damage, and that's important for skeletal strength. So if you think about why would the bone continue to do this, it actually heals all the microfractures that occur as we're weight bearing, and it also is important for supplying calcium to maintain serum calcium. So this is a schematic of the bone remodelling unit, and this whole process takes up to about 3 months. It starts off with the lining cells, which are osteocytes. They get activated predominantly due to mechanosensin. So it's predominantly in weight-bearing sites that this occurs. They then stimulate osteoclast precursors, osteoclasts being the cells that chew away the bone, leading a resorption cavity. Then and then the osteoclasts then stimulate the osteoblast precursors to come down, lay down osteoid, which then mineralizes. And so this process is called osteoclast-osteoblast coupling, and that's relevant, which I'll talk a little bit later in terms of the treatment options and how that affects the type of bone that gets built back. This whole process, as I said, takes up to 3 months. So as you can imagine, it's a relatively quick process, considering this is occurring lifelong. And it's important to know that in different pathology in particular, different parts of this process will be arrested. So you can have conditions in particular with immobility, where you have a lot of resorption happening and you have essentially osteoclast-osteoblast decoupling. So you've got a lot of osteoclast resorption happening and no subsequent osteoblast formation and bone formation. And that's one of the reasons you get a lot of bone loss in immobility. Or in an ICU state where you've now no longer got all that mechanosensing going through the bones. The hormonal side, obviously, from my point of view, is the interesting side. This will be pretty straightforward, but some of the hormones that are important are osteoprotein or OPG and rank ligand. So rank ligand is a signalling molecule that communicates between the osteoblast and the osteoclast. And as you can see, in conditions of pro-resorption, the osteoblast secretes more rank ligand to stimulate the osteoclast to form from sort of these pretty basic cells initially into these multinucleated osteoclasts like ginormous macrophages. And things that will stimulate that include PTH and also inflammatory cytokines, which is why people who have something else going on, which everyone always does, but particularly in the very sick, that's another reason that the ICU patients or the sick patients really get some severe bone loss. On the flip side, anti-resorptive, or anabolic. This is when you get OPG that comes along and it's like a decoy receptor. So essentially it binds all the rank ligand so that is unable to bind to the rank ligand receptor of the osteoclast so that the osteoclast can't be activated. And estrogen in particular is the important one here. Estrogen works by stimulating this, and so you can imagine when, in women in particular, or even hypogonadal men, when you don't have the sex hormones around, this process is lost, and so you're in a pro-resorptive state. So osteoporosis, you would all know this, systemic skeletal disorder characterised by reduction in bone mass and disruption of bone microarchitecture. And the important thing is to think about what exactly is a fragility fracture. We think about renal failure, we think about heart failure, we think about lung failure, that's all really easy. You should think of fragility fractures as bone failure, because the primary function of the bone in this context is to support and to provide structure for the body. And if it fails, if it breaks, it's no longer doing that. And the way I think of a fragility fracture is a fracture that you would not expect a young, healthy person to sustain. So currently the guidelines say that it's if you have a fracture after a fall from standing height or less. But even sometimes you talk to women, or not just women, but all patients, and they say, oh, look, it was a really hard fall. I really landed down on my back or whatever. But if you say to them, oh, if you were 20 years old, or if you were, my age, would you expect that to have happened? And then they say, oh, maybe not actually. And so that's actually what a fragility fracture is. It's when previously this force would not have been sufficient to result in a fracture. And currently in Australia, over 4.5 million people over the age of 50 are affected with either osteoporosis, osteopenia, or poor bone health, and that costs almost $3 billion a year. And this is only projected to increase, especially with the ageing population. So if you think about it, that's 2/3 of people, which means that's a lot of people that are getting affected. If you think about the number of people that are being managed for osteoporosis, we're not even close. So the determinants of osteoporosis essentially relate to your peak bone mass and then how quickly or how much you lose. Peak bone mass, by the time that we see them in adults, is all over really, but it's going to be predominantly genetics and anything that's happening in nutritional and during puberty, the nutritional status of that person up into puberty. And then bone loss is the main thing that's going to be relevant for our patients, and that's due to age-related decline in general, and then also when there's increased remodelling activation. And so that can occur both in the trabecular compartment as well as the cortical compartment, which is relevant for different sites within the skeleton. And so this just shows you that really your peak bone mass is, I tell patients, really by the time they're 30. So when we think of osteoporosis, we often think of it as an older person's disease. We don't think of it for anyone who's less than 50. But really, by then, they're already on the downward slope. And if you can imagine that with women in particular, if they go through the menopause early, this curve is shifted this way, and patients are going to lose bone and have much weaker bones much earlier. So it's very relevant, especially with our old ageing population. The risk factors for osteoporosis, you'd all know this. The important ones to think about in terms of potentially modifiable ones, in terms of lifestyle changes. I'll talk a little bit about the evidence for calcium and activity. But then obviously with my work, I think a lot about the secondary causes and what other things we can be doing to minimise rapid bone loss. As I mentioned before, chronic inflammation is really important, and you'll see patients who have some inflammatory condition. You know, rheumatoid arthritis is one of the worst ones, and they've got so many factors. They've got uncontrolled inflammation, they're on prednisone, they've got poor mobility, they've got poor nutrition, everything is against them there. And so these are the sorts of people that, from my perspective, you say, look, I know prednisone is never good for bones, but if it actually treats their underlying condition, actually that might actually be better for them, and you tolerate higher levels of prednisone in those cases. The other thing to think about, particularly as we're getting a lot of bariatric patients now, and changes in people's diets, malabsorption is very important, and people who are on restrictive diets, people who are avoiding dairy in particular, or avoiding protein in particular. It's important that these people, whether that's iatrogenic or not, that these people, they're not going to have the essential nutrients to build bones. So both in terms of pathological conditions or in lifestyle changes. And there's a long list of drugs that can affect bones, obviously. This is just a really brief list of them. But essentially, the things to think about in a lot of your patients will be anti-epileptics and some of the influence that they can have. People who become unwell and have, I guess, a functional hypergonadism. I can't see where I'm pointing, but relative hypergonadism is important. So if that's a prolonged illness, then they're going to have that as well. And I think those are the main things, yeah, immunosuppression and chemotherapy, which is pretty obvious. And the most important thing to think about is that with osteoporosis, there's bone fragility or weak bones, but then there's also the risk of falls and the effect that some of these medications and some of these other conditions are going to have on a patient's ability to maintain their mobility. So why does all of this matter? Because this is all pretty straightforward to you. But the impact of osteoporosis and fractures is actually far beyond than what most of us would usually think. There's the direct effects of the fracture itself. And this is a study, this was one of the early work that was done by the group in the Garvin, and they looked at the Dubbo cohort, which is the longest running epidemiological study in Australia, looking at the fractures that occurred in the population. And the first thing to note is that, as you'd expect, a lot more fractures occurring in women compared to men, but men still fracturing a lot. Second thing is that any bone can fracture, but the ones that are most common are going to be the ones that usually don't always cause a patient to go into hospital necessarily. You know, you see the hip fractures, they're all going to go into hospital, they're going to have a prolonged rehabilitation time, but the patients that fracture the most of those who have spine, forearm or wrist deformities which lead to a significant functional impact. You can imagine someone who is a little bit elderly, who's just coping at home, and then they go and have a wrist fracture. Now they can't cook, now they can't shower, now they can't clean. It's going to cause them a lot of functional disability. And so these are the sorts of people that we really want to keep them in the community. We want to keep them well. I'm sure I'm preaching to the converted here. These are the sorts of people that we don't think about as having a significant impact necessarily from a fracture because we don't see them in hospital. And same with rib fractures. How many times have you heard people talk about how sore they were after that, then they got pneumonia or something as a result of that? So it's these sorts of other fractures that we don't always tend to think about as being fragility fractures, but have a significant impact for the patient. With vertebral fractures in particular, you can see here, this is a picture of a normal vertebrae and then what happens when you get a fracture. And as a result, they lead to significant kyphosis, and this has significant impacts in terms of both their respiratory function, abdominal function, in terms of satiety, constipation, urinary retention, and of course mobility and quality of life. So the direct effects of the fracture is that you get pain and discomfort immediately, but actually the local disability can be quite significant and quite prolonged. And this can lead to lots of other significant effects in terms of the patient's ability to function, particularly in whatever environment they're already used to. The risk of further fracture. So this was, again, from the Dubbo cohort, and this is looking at the absolute number, so the risk per 1,000 person years for your risk of a first fracture. And as you can see, women in pink, men in green, as you'd expect, more in women compared to men. And as you got older, your chance of having a fracture increased. This is for your first fracture. But what happens if you've already had one fracture? What does that do to your subsequent risk of fracture? Well, you can see that actually it increases significantly, and actually the relative risk of a subsequent fracture then was almost twofold for a woman. So that is to say, if you were a woman and you were aged between 60 to 69, your risk of having a fracture, because you've already had one, was doubled. And if you were a man, it actually was increased by almost 3.5-fold. And what you can actually see is that's quite significant, such that a man who was 60 to 69, if he's already had a fracture, his risk of a refracture is actually higher than a woman who's 20 years older than him. So a fracture almost ages you by 10 to 20 years in terms of your risk of a refracture. And I'll show you later, but when we think about the younger elderly people who are there and we're trying to keep them functionally active, we've aged them by 10, 20 years in terms of their risk of a fracture and all of those effects that you get from having a fracture. And what this study also found, is that the effect of this lasted for 10 years. So that is to say each fracture increases your risk for a subsequent fracture for 10 further years. That's if you even make it, because as I'll show you, mortality is significantly reduced. So each fracture counts significantly, both in terms of the risk of a subsequent fracture, but also for how much longer it's going to affect you. And as you can imagine, the more fractures you get as well as all of the other things, it increases your risk of falls, your mobility, independence. It's a big downward spiral. So the risk of further fracture, the risk for men is similar, if not at least greater, really, for men than for women. The risk is at least as great for someone that's 10 years older, and the effect lasts up to 10 years. And then the final thing to talk about is death or premature mortality. The age-standardised mortality risk is increased by 2 to 3-fold after all types of osteoporotic fractures. So as I said, we know that hip fractures in particular have a significantly increased mortality rate, so 3-fold in men. But even with vertebral fractures and other major fractures, you have at least a 1.5 to 2.5-fold increase in mortality simply by having a fracture. This is adjusted for comorbidities and those sorts of things. Here, this is again from the Dubbo cohort. You can see that on the left side is the 60 to 75-year-olds, and on the right is those who are over 75. This is for women, and this is the mortality for the general population out to 15 years. If you've had a minor fracture, so it's usually like a distal fracture, that decreases your mortality. If you've had a major fracture, a vertebral fracture, or even a hip fracture. So you can see now your mortality's gone from almost sort of 0.6 down to 0.4. And you can see, especially for older people, it's quite significant. And this goes out to 15 years, but you can see that there's a big drop, particularly in the first 1 year and even the first 5 years in particular. So these people are dying quite soon after they're having their fracture. And it's the same picture for men. Potential years of life loss, you can imagine it's quite significant both for men and women for all types of fractures. It's not just the hip fractures that we mostly think of. And it equates to many life years lost. So premature mortality is quite a significant issue with fractures. It's associated with all fractures, and the subsequent fracture increased mortality is for at least 5 years after that fracture as well. So that's why we need to think about it. We know it's a common problem. It's more than just a broken bone. It's not just fix the bone, they'll be okay. It has a lot more implications for that, for the patient. So how are we going to help manage them? When you think about diagnosis, the two most common ways people think of diagnosing osteoporosis is either on a low bone mineral density or if they've had a fracture after minimal trauma or bone failure. DEXA is the most common way that we detect low bone mineral density, and that's defined currently by the WHO as a T-score of less than -2.5, which is matched for gender but not for age. A fracture after a minimal trauma, as I said, is a fall from standing height or less, including spontaneous. And as I said, I asked patients, would you have expected a young person or you yourself 20 years ago to have fractured? In case you don't know what a DEXA is, it's dual energy X-ray. So essentially it's just two beams of an X-ray. So it's relatively low radiation for patients. This is how you do it. They have to sit on a bed and this machine goes over them. So it's actually quite straightforward. It's not an MRI. People, for some reason, a lot of patients think a DEXA is going to be quite invasive, but it's not. And it uses the different density of bone relative to soft tissue. I think I was going to say, I'll show you later, yeah. So interpreting the DEXA is determined by using reference values for a young normal population. So that's people, so the same gender, but people who are sort of around 30. And as you can appreciate, there'd be a bell curve for what is normal, and osteoporosis is defined as -2.5, so sort of in the less than 2.5% percentiles. The Z score, if you ever think about that or see that, is age matched and also adjusted for body weight. So people who are very obese, as you can imagine, because of different densities in the tissue, the Z score is more useful for that. And if someone has a very low Z score, so that is they've got a very low bone density compared to someone their own age, then you should think about a secondary cause of osteoporosis, so something else that's driving it to make them weaker compared to their similar aged people. This is an example from bone density at St Vincent's, and each place will obviously do it differently, but generally you'll obviously have the spine and then you'll have the hips. The spine is usually done for L2 to L4, but people who have degenerative disease or vertebral fractures, that will be adjusted because it becomes irrelevant. This, at St Vincent's, they do both left and right. You probably don't need to always, except if there's significant discrepancies between the two. And if you're thinking about, oh, which one do I use? You know, this person's got a -1.2 here, but -2 here. That's sort of quite different. I generally think you should use the lowest value because that's going to be, you know, that shows that at least in that area they are weaker. And you probably should think of mostly the femoral neck as the one for the predictor that you'd want to look at. A lot of good places now will have the absolute fracture risk estimate, and that helps you guide you to determine how likely this person, based on their age and their risk factors and their bone density, is likely to go on to have to sustain an actual fracture. And this one is helpful, but essentially if someone has a hip fracture that's more than 5% or any fracture that's more than about 10%, that makes you very, very worried. Oh, sorry, I went through all that. It's helpful when you tell patients to, ideally they can go to the same place. There's different machines. This is a Luna machine. They have to be calibrated, so ideally you want to compare like for like, and even better if you do it at the same place, because then you can see how exactly they change, because a change of more than about 4% per year would be considered very high bone loss and should make you concerned. This just shows you a standard spine, one where this person's clearly got a bit of scoliosis, they've got degenerative disease. This is going to affect their bone density results. Maybe you can see it in your printout, but you can see that individual vertebrae will be listed, and you can sometimes see that they can vary quite differently between each vertebra. So when should you do a bone density for the diagnosis? I write after a fracture, but technically by definition, if they've had a fragility fracture, you don't need it to diagnose them with osteoporosis. They by definition have bone failure and by definition have osteoporosis. You should use it for screening for high risk conditions, and that's the certain medical conditions are the ones listed before, things like hypothyroidism, hypogonadism, rheumatoid arthritis, inflammatory bowel disease. Currently, Medicare only reimburses for population screening over the age of 70, which is really too late, let's be honest, because by the time they're over 70, you've missed a lot of fractures probably and missed a lot of people who could have been treated. In the other time you use it, obviously, is monitoring effects of treatment. Medicare allows that to be done after the first year, after 12 months for the first time, and then thereafter every 2 years. But to be honest, you've got to think about whether or not actually the bone density change is actually going to affect your management decision, because a lot of these people, if they needed treatment to start with, they're probably going to need it for longer, and your bone density isn't actually going to change your decision. Sometimes it's more just to see for efficacy of treatment. As I said, our current screening strategies are not effective. Vertebral fractures are silent in up to 2/3. And in a population-based study of women over the age of 70, about a quarter of people had a vertebral fracture. About a fifth of people had a low bone density on DEXA, but actually only 7% of them overlapped. So that's saying that up to 20% of people had a vertebral fracture with normal or not low bone density. So clearly we're missing people if we're only thinking of DEXAs when they hit 70. They're already going to have had fractures. We're missing people when we're not thinking about causes of what might be causing them pain, or if they've not had a screening X-ray. And this brings me to this point, which is that the majority of the fractures are actually in the young old. So on the left is the absolute number of fractures per age group, and they're just divided according to the different fracture types. But you can clearly see that as you get older, you fracture more. But then this is, that's the relative. This is the absolute number. So you can see that the absolute number is highest, mostly actually in the younger age group. So it's this group of people before 70 that are actually fracturing the most. So if we're waiting till people are fracturing before we think about bone density, then we've really missed the boat here, because these people are already going to suffer all those consequences that I mentioned before. They're essentially aged by at least 10 years already by their bones. So this is, hopefully you can read this in your handouts, but this is what I think about when I think about assessing a patient. A lot of these things are irreversible, as we said, but it's about managing them and treating the underlying condition if possible, minimising drug exposure. If I'm thinking about osteoporosis at all, everyone really should get these basic investigations. And anytime you've got someone who's got any abnormality in their calcium or PTH balance, you should just do a urinary calcium to creatinine ratio. You don't have to do a 24-hour, you can just do a spot urine. That gives you an idea of if they've got high urine output, and therefore that helps in your diagnosis of why they might have calcium PTH imbalance. They should get a BMD by DEXA, and if they've got normal T-score, that's great. If they've got a low T-score, less than -1, so anything that's osteopenic even, they should go on to have a screening thoracolumbar X-ray, because as I mentioned, up to 2/3 will have been silent. If they have a low Z score, then you should think about the secondary causes and then consider their treatment options. This is a list of some of the secondary causes, of which will sometimes be very obvious, like if someone's got chronic liver disease, obviously you'll know about that. But I think what happens is in some of these conditions, the osteoporosis isn't thought about because it's not deemed to be sort of the important issue. I accept that, some people, especially with chronic liver disease, their mortality from that themselves already is so high. But if you think about those people who are high risk for fracture, if they just have that one fracture, is very often their terminal event. So you're working, with all of the new treatments to try and prolong life in all of these people. If they have a fracture and that's what causes them to die, when we could have prevented that, in a lot of ways, we've done the patients a disservice. So the extra investigation to think about if you're screening someone in particular is to think about a pituitary screen, in particular looking at their sex hormones, a celiac serology, and as well as to look for multiple myeloma. Any questions at this point about this stuff so far? Sorry. Yeah. So 20% high loss, and what's important to look at is whether it's just concave, so one side, or if the whole thing is a crush down, so 20%. The risk calculator, there's two current big sort of risk calculators that are used worldwide. There's the Garvin fracture risk calculator, and you can access that freely online. It's very easy, very straightforward. You just put in gender, age, and what it does take into account is the number of fractures that they've had since the age of 50 and the number of falls, because these were the two things that were found to be most significantly predictive for subsequent fracture. You don't have to have a bone density, but if you do, that's good, and then you can enter it all in. As you can see, it's pretty crude. There's actually not that much information you need to put into it, but that is sufficient to predict a patient's fracture risk. And then what it does is it tells you your 5-year and 10-year risk of any fracture with and without treatment, which we'll go through later, but you can see that with treatment, we actually can reduce your risk of a fracture by up to 50%. The FRACS predictor, that's done predominantly by the group in the UK, and it uses a worldwide cohorts of different communities. And it's a similar concept where you put in different risk factors. Now there's a few more things that you would traditionally think of to be risk factors. So weight and height, so both particularly underweight people, previous fracture, family history of fracture, smoking, steroids, rheumatoid arthritis. The trouble with this one, or one of the downsides of the FRACS, is that it doesn't sort of, it dichotomizes your risk factors. So it just says, do you smoke or not now? You know, so someone who's been smoking all their life until now, you know, probably should be a yes. Also doesn't talk about how long or how much glucocorticoid you're exposed to. But it's just another way you can use it. It's a different risk calculator that you can use, and between the two, they will both tell you similar things, that this patient is either at high or low risk of a fracture. So moving now to the management approach, and this is where the first part is applicable to all patients, really anyone who you've even thought about bones, even if they've got normal bone density. The first is adequate calcium, and preferably this should be done through a dietary means, 2 to 3 serves, and this is an example of 1 dietary serve of calcium. Whenever you talk to someone about how much milk they have, they always say, oh, I have heaps, I have lots of tea and lots of coffee. But if you think about how much milk you put in a tea, it's actually not very much. So unless they're having like 5 or 6 or 7 glasses of tea a day, they're not getting enough milk in just a cup of tea. And one way that I ask people is, if you've got a bottle of milk at home, how long does that take you to go through it? And if you've got a litre of milk and that takes you more than a week to get through, you're clearly not having you're not getting a daily serve of milk a day. There is some controversy about supplementation with calcium, and most of the studies that showed an increased risk in cardiovascular disease have been criticised because they weren't adjusted for the baseline dietary calcium intake. So the ones where there was an increased risk of cardiovascular events probably occurred in those who had at least 2 to 3 serves of dietary calcium to start with. So someone is getting their daily calcium, they don't need to be on a calcium supplement. Conversely, if they've got low dietary calcium and there's this concern about cardiovascular risk, they're probably actually not at an increased risk, but that should be discussed. In terms of the supplementations, there's calcium carbonate, which is caltrate, or there's calcium citrate, which is citracal. Most people hate both of them. Caltrate, as you know, is ginormous. No one likes it. You can't crush it. Citrate's a bit gross because it's fizzy. You just have to get whatever they're going to take, essentially, if they're not going to have any dietary stuff. The carbonate in particular is particularly affected by absorption. So people are on a PPI, or if they're on an antacid, they're not going to absorb that calcium very well. So just keep that in mind. So sometimes I tell them to take it away from their other medications for that reason. Ensure patients have an adequate 25-hydroxy vitamin D level, and you'd be surprised that there's controversy as to what is considered adequate, but probably at least 50, if not 75, especially if they've had a fracture, is what I would aim for. You'd usually use 1,000 to 2,000 units of cholecalciferol. If they've got renal failure, you'd put them on calcitriol, which is activated vitamin D. There was a study that showed that there were increased falls seen in those if you were given a bolus dose of oral 500,000 units, but that was again probably only seen in those who had adequate levels to start with. So anyone who has a low level, so some labs will measure down to less than 15 or even less than 25, it is probably safe to give them a bolus dose, which you can either do orally or you can do in an intramuscular form. That's 100,000 or 300,000 units. It's fat soluble, which means that you can do that, you can bolus people, and there is a new preparation that's 7,000 units in one pill, and that's supposed to be easy, so you can take that with your weekly Fosamax or weekly Actinel as well. So whatever you need to do to get these people to get some into them, you can also do compounded vitamin D, where they get about 50,000 a month. And if they're really requiring high doses of it, or they're persistently D deficient, you've got to think about malabsorption, and that might be contributing both to their vitamin D insufficiency as well as their underlying bone disease. Exercise, nice and controversial. Lots of media about exercise and how wonderful it is for your bone density. The evidence for bone density in adults is minimal at best, and there's definitely none for fracture prevention. It's only really when it's combined in a multidisciplinary way that it's been shown to help with osteoporosis. But what I do tell patients for exercise is that it's about maintaining muscle strength and flexibility. As you can imagine, fractures occur usually because of falls, and so if they're falling over because they haven't got good reaction time, they haven't got good flexibility, that's a concern. And so they're the people, that's what you want them to be doing, and it's graded exposure obviously to exercise. And then of course consider other lifestyle factors.
Sorry, what's the intensity of exercise using your studies? Is there any intensity in terms of exercise?
I think when they, the papers that have reported on it talk about a graded process. I'm sorry, I don't know the unit of measure of how they graded it. Certainly it's always a graded exposure. And particularly with people who have very bad vertebral disease, spinal osteoporosis, you'd want to be very careful about doing some of those stretching exercises. So who should you consider an active agent? Anyone really who has had a previous fracture should be considered for an agent. Low bone mineral density, anyone who's had documented significant decline, and that's usually going to be around the perimenopause, or which includes natural or induced, and anticipated decline, for example, around transplantation. So someone who you know is going to have a whole heap of steroids, and their renal function is going to go off, and they're going to get tacrolimus. So they're the sorts of people you think about preemptively treating. This is a schematic of sort of the currently available agents available. So I'll just step you through it because it is a little bit busy. As we said before, there's the osteoblast here, secreting rank, which is going to bind to the rank receptor, rank ligand to the rank receptor on the osteoclast precursor. And then there's activation of the osteoclast leading to resorption, then bone formation and mineralization. So bisphosphonates, which you would all know about, are designed to poison the osteoclast. So that means that's an anti-resorptive, means that you don't get that initial decrease in bone, initial increase in bone resorption. This can be a problem when you think a little bit later down the track, in that it's only decreasing resorption. It's not actually anabolic at all. It's not actually building up bone. And because of the osteoclast-osteoblast coupling, you've switched off the osteoclast, which means you've switched off the subsequent osteoblast too. Does that all make sense? So that's an anti-resorptive effect, and there are concerns which I will go through later as to why that could be a problem long term. Denosumab is a rank ligand antibody which blocks that, and so you don't get activation of osteoclast, so it's also an anti-resorptive and works by the same way. The hormonal-based therapies, including straight hormone therapy as well as selective estrogen receptor modulators or tibolone, they work by, again, increasing the rank ligand area loop, so it's predominantly an anti-resorptive effect. And then there's the anabolic ones here, which is synthetic parathyroid hormone, which when used in a pulsatile way is anabolic. So obviously continuous high exposure to parathyroid hormone, to hyperparathyroidism, that is bad for bones. But in a pulsatile way, which is what is used for Forteo, that leads to intermittent stimulation, and that is bone forming. That's Forteo, that is a daily injection, and currently is the only anabolic therapy available in Australia. So the holy grail obviously is to look at anabolic therapies to actually build backbone rather than just breaking down, stopping a resorption. That's that all in word form. Currently, probably the most common things you would see people and would probably be denosumab because it's so good and it's so easy. There's a lot of controversy about the estrogens, which hopefully I'll get to talk about really briefly. You still see a lot of the bisphosphonates as well. This is for your reference later, just so you can read up, just if you want to look at that later. This is all the bisphosphonates. Essentially, they're very safe to use, and the main thing about the oral ones is just to think about the oral side effects, the GI side effects, so esophagitis, but Actonel comes in an enteric-coated form, which means that it's much better absorbed and can be taken with food. Zoledronic acid is IV, and the main issue with that is that because it's IV, you do get this acute phase response, but usually that is actually most prominent the first time they get it, and subsequent doses they won't have that same infusional reaction if you can convince them to take it. Denosumab is, as I said, really quite good. And as you can see from the fracture prevention, it's actually been very good at reducing vertebral fractures in particular. It's up to 70% there. The key thing about denosumab is that it's got to be given every 6 months, and that's new data that's come out in the last year or so, that people who miss that dose, there's an increased risk of hyperturnover. So there's release of the suppression on the bone turnover that goes sort of in a crazy chaotic way, and there's risk of a severe vertebral fractures if you miss that dose. So that's important to think about people who might have too many medical conditions, and they're in and out of hospital, it just gets fallen off the list of things to do. Yeah. How long's a piece of string? So usually I tell people up to a month after or before, and if they're going to be away for some reason, it'd be better just to give it early rather than late. The hormonal-based therapies up the top here. So Evista and Tibolone or Livial are the most commonly ones used predominantly just for bone. The guidelines do not support using straight hormone therapy purely for bone protection. Tibolone in particular is good because it was marketed as a menopausal drug, but was found to have significant bone benefits both for vertebral and non-vertebral fractures, and it has some benefits in some menopausal symptoms. Evista also was good particularly for vertebral fractures, but there's no data, no significant improvement in non-vertebral fractures, and it can exacerbate some menopausal symptoms. So you might see some people still on this, but I don't generally find a lot of people where that will be useful, because if they're perimenopausal, which is the group you would think to use this in, you're always concerned about exacerbating their menopausal symptoms. And hormone therapy also has had a lot of bad press. It's always about understanding the risks and benefits of these treatments. In general, the side effect profile is very safe, apart from an increased risk of stroke in those who are a little bit older. So if you've got someone who's somewhere in the age between 50 and 60, they've got menopausal symptoms, they're going to lose a lot of bone. So perhaps they've just had a baseline bone density. It's not too bad, but they're going to lose it, and they've got a family history. Actually, Livial is a really good drug for them, and I have a lot of people who are on that. It's not currently PBS listed, but the cost of it is actually about the same as a PBS drug. PBS script. And then there's teriparatide, as I said, which is a daily injection. So that can be concerning for people. It's a daily injection like insulin, so it's totally fine. There's nurses that can teach you how to do it, and then they will find it fine. Currently, the lifetime exposure in Australia is limited to 18 months. Worldwide, it's 2 years, and that was because of the theoretical increased risk of osteosarcoma, which has been seen in animal models but not in humans. The issue with teriparatide is you get it once in your life, so you have to think about timing it when you want to give it to a patient, and PBS criteria is quite strict with who qualifies for that. This just shows that fractures are reduced by treatment, mortality is reduced by treatment. I'll just skip over that. Which one would you want to use? There's no head-to-head trials, probably because no one wants to lose. BMD gains are probably the best in denosumab, but probably is just as good in IV zoledronic acid, which is greater than the oral bisphosphonates and estrogens, and that could be due to absorption. And as I said, the main consideration is tolerability and side effects, as I've listed there. So just really quickly on the issues with anti-resorptives, why people are so scared about this, and when you Google it, this is the first thing people see, and so they think this is a bigger problem than their bones themselves. Osteoporosis, and the comment I should just make is that all of these issues are relevant to all of the anti-resorptives, so both bisphosphonates and denosumab, so it's not a reason to change between them. Osteoporosis of the jaw, by definition, is exposed bone persisting for more than 8 weeks. As you can see, the risk is actually very low. in osteoporosis patients. It's higher in those with malignancy, and that's due to some of the risk factors, which include increased dosing. So denosumab is 60 milligrams twice a year, 120 milligrams a year. Xgeva, which is denosumab for cancer patients, so breast and prostate with bone malignancies, is 120 milligrams monthly. So they get 12 times the dose. These are the sorts of people that are going to have more risks associated with it. There's often other things as well going on though, so bad oral hygiene, immunosuppression, radiotherapy. The management here is that ideally you think about sorting out their teeth beforehand. It's controversial as to whether stopping the medication is actually of any benefit and whether you should even use bone turnover markers, probably not. But probably the most important thing is to use antibacterial mouthwashes and oral antibiotics. If it's possible, I say you at least time your tooth extraction just as close to your next dose. So, if you're getting your dose of denosumab in April, your next due in October, so maybe in September or August is when you go get your teeth done, if possible. Atypical femoral fractures. Has anyone ever seen this at all? Yeah, a couple. It's actually coming out a bit more than you'd think. I think I've seen definitely more AFFs than ONJ, even though actually ONJ is what everyone's more worried about, I think, because dentists talk about it more. So an AFF or an atypical femoral fracture is a spontaneous femoral shaft fracture, which of course in the world of osteoporosis, if we cause a patient to have a fracture, we've done the worst thing we can do. It's a little bit more common than ONJ, but still very rare, and it's probably related to oversuppression, although we're not sure the exact mechanisms. People who have had this happen to them and they've had bone biopsies, it doesn't really give us much idea. But what we do know is that patients usually have prodromal pain, and what they describe is right in the mid-shaft. So what we describe is right, put your hands here, right on your thigh. Right on your thigh, not in your hip. Everyone has hip pain. It's right in the middle of your thigh that you get the pain, and it's often bilateral. So if someone's describing pain on one side, you should always image both sides. You'll do an X-ray, and you can see the typical features before they break is this cortical beaking and thickened cortices as well. And it's usually transverse. And you can see this is a patient who had a fracture here, and when they imaged the other side, there was also evidence of this developing on the other side. If this happens, or if the X-ray is negative, then you should go for a bone scan. Then they need an orthopaedic review with a rod and get rods put in. And this is what sort of brings up the question of should patients have a drug holiday because of the increased risk of this with drug exposure. So I don't have a lot of time to go through it, but basically you should think about your initial indication for why that patient went on treatment. Overall, the risk of ONJ or an AFF, for one fracture, one AFF or ONJ episode, you would prevent 100 hip fractures. So people see the side effects, and they're terrible side effects, but if you think about the number of fractures you've prevented with treatment, sometimes that gives you an idea as to what are the risks and benefits. So someone I would think about having a drug holiday is someone who had a relatively soft indication for treatment to start with, and that would be someone who maybe has osteopenia only, and they've been on treatment already for 5 to 6 to 7 years already, because we know by then that their risk of a subsequent fracture has decreased. Yeah. If someone's still osteoporotic, so they've still got a T-score of -2.5, their risk, and they're older than they were before, they're still going to be at increased risk of a fracture, so they probably should stay on treatment. If that happens, you're a bit stuck. There's not a lot of options because this is relevant to both denosumab and bisphosphonates. So there's not a lot of evidence, but some people have anecdotally used Forteo in this instance, but otherwise the patients are really stuck in this situation. Yeah, that's also some new evidence that's come out for that. So what we actually tend to use is we use bisphosphonates to cover that period of increased bone turnover. And the question as to whether you use IV, zoledronic acid, or orals, my preference is to use oral. So that is to say, you say they were April and October comes, you're not going to give them their dose of denosumab, you start them on oral bisphosphonates instead to cover that period to slowly reduce the suppression on bone turnover. 6 months, about 6 months. There's not a lot of people, though, that you would think about taking off denosumab, except really these drug holiday people, yeah. But the data for denosumab is better than the bisphosphonates for long-term exposure. The trial that was the Freedom trial, which was the big pivotal trial, has been gone out to 10 years now, and those out to 10 years compared to 5 years, there wasn't a significant increased risk. So denosumab might be a little bit different in ways we're not really sure. Sorry, say that again. Yeah. So this question. So severe osteoporosis, what do you do? So ideally you'd be looking at anabolic therapy, and currently we only have teriparatide, which the PBS says that you must have fractured on anti-resorptive treatment and you must have a T-score of less than -3.0. So a DEXA scan often won't show that, and so one way you can do it is by looking at bone density by other means, and there are things called QCT or quantitative CT, and that's when you look at individual vertebra, and pretty much whenever you do that you'll always find something that is going to be less than -3.0. So if someone has fractured on denosumab or anything, teriparatide is usually the one that you'd want to put them on, as long as they're willing to do a daily injection and they don't have a history of malignancy, is really the only major contraindication. Is there evidence for switching? So say they were on an oral bisphosphonate and they keep fracturing, do you switch to a parenteral? Probably, maybe, yeah, probably better. Although within parenteral therapy, there's not really much benefit. And just really quickly, just on bone turnover markers, in case anyone's heard about them and are interested, there's essentially the markers of formation and there's markers of resorption. And this is the byproducts of when there's collagen formation in the bone. There's a lot of different ones, and every different endocrinologist has their favourite ones to use, but the WHO is trying to encourage people to use the same ones all the time for standardisation. So P1MP for bone formation, CTX for bone resorption. To be honest, there's limited use for them. Sometimes people use them at baseline before commencing therapy, to sort of confirm if someone's got high bone turnover, because you need to wait at least 12 to 24 months to see changes on their bone density. Sometimes you do it for monitoring response to therapy, particularly in someone who's on oral therapy or their bone density isn't doing what you're expecting it to do. The timing of dosing, so whether or not you use that as a marker to say, I've covered you enough with your bisphosphonates when I'm trying to take you off your denosumab, that's a little bit more controversial. There's just some caveats about bone turnover markers, though. In renal and hepatic impairment, you can't use it, and it's a bit strict about how you have to take it. So that was my last slide. So I'm happy to answer any questions about any of this.
Ask about the duration of this phosphonate. Some studies show that at a certain age there's no benefit anymore. And what's the current guideline?
Yeah, so that happened in the FLEX study, which was looking at alendronate. And what was thought and what was sort of published about it was that after 5 years, people didn't have an ongoing benefit. But that was when you look at the whole cohort. When you look at the people who had actually low bone density, they continued to have ongoing benefit. So they did continue to have reduced fracture rates compared to those who stopped treatment. It was in that cohort, and also low bone density and those who had a previous fracture. So it's actually the high risk people that would still benefit. So there was that study, and then because of the risk of AFS, that made everyone say that's why you should have a drug holiday. So it comes back down to the beginning of, why did this person really need the treatment to start with? If someone has a T-score of still less than -2.5, they still should be on treatment, really, unless there's another reason. Like a drug holiday really isn't a good reason. As I said, the only time would be someone who's got osteopenia, their fracture is at least 5 to 7 years ago. Maybe they're very young in particular, so you're worried about their lifetime exposure. But remember now, usually if they were sort of 55 and they had their fracture, now they're going to be 62, somewhere between 60 and 65, which means they're going to be hitting 70 soon, and their absolute risk of a fracture is only going to increase just by age. So, yeah, there are people I will take off treatment, but it's far less than I think we used to.
high dose and then continue with them?
Yeah. So generally the study that showed an increased risk of falls was probably seen in those who had normal or high levels at baseline. So if they've got normal levels, then they obviously don't need a mega dose. But if they've got low levels, so undetectable, less than 15 or even less than 25, I would still give them a bolus dose. And then
What is your recommendation dose?
whatever you can get your hands on. So different hospitals will have 100,000 or 300,000. It's SAS, so some places don't have it, some private pharmacies will have it. That's easy, especially in a hospital patient. Otherwise, you can give them a bolus sort of 50,000 oral dose, which you can get compounded, and some people will stay on that forever as well. Yeah. Yeah, this is really controversial. So if you talk to a surgeon, they may say something different. Certainly the trials where they looked at the Horizon trial, which looked at zoledronic acid, peri-hip fracture, that didn't show any decreased rates of you know what I mean, the thing going in, prosthesis, engraftment, and actually had a mortality benefit. So for zoledronic acid, I'm very comfortable giving that as soon as possible, because these are the people that are going to go out of hospital and no one's going to think about their bones. What about denosumab? That's a bit less understood, what effect that will have on healing. I've heard some surgeons say that it does affect it, and I've heard others say that they don't care either. So I think, to me, as long as they get it, I think is important. If you really want to be safe, if you're concerned about there's something about the pin and plate not holding, so some particularly wrists in particular, then you might say wait till that's healed completely. But that can be, 12 months sometimes.
So thank you so much. I know it's a complex topic, but the way you have presented, it looked easy to us. So thank you so much. Please join me in thanking everyone.